Thanks a lot. It's a great pleasure to be with you this morning and to talk about how to assess peripheral perfusion. We all know that the real goal of our resuscitation is to try to prevent tissue hypoperfusion and to give enough oxygen for the cells. And, but the problem is that we are very disappointed when we think about how I can manage this at the bedside and what is a good tool to be sure that my resuscitation is okay for tissue, okay for different tissue. So we are most of the time completely blind concerning oxygenation, tissue oxygenation, microcirculation, and incapable to know if the tissue is capable to use oxygen. So the goal is to try to be sure that there is no occult hypoperfusion, and that macrocirculatory optimization is effective to improve microcirculation. Just some example to show you how the picture is complex and the story difficult. So we monitor microcirculation at the sublingual level in hemorrhagic shock patient. And we try to see the time course of these parameters at day 1, day 2, day 3, and day 4. We were not satisfied, but clearly very enjoyed by the resuscitation that we performed. The arterial pressure was okay, and the hematocrit level was within the recommended range, and lactate was still elevated during the first day, but after we get a great normalization of lactate. So we think that we did a great job. But when we look at the microcirculation, at the sublingual microcirculation, we had clearly a problem. We had clearly an alteration of microcirculation. And this alteration of microcirculation could have an impact on the SOFA score, because when in patient where we have the most deep alteration in microcirculation, we observe a higher SOFA score at day 4. So it could be because we give too much vasopressor. It could be because we are not enough focused on the fact that we have to decrease as quick as possible the concentration of vasopressor, or maybe we give not enough fluid, or maybe even if the hemoglobin level was within the range, we don't give enough blood. Another study that we perform is in septic patient, preload dependent severe septic patient, where we perform a fluid challenge and we perform 2 successive fluid challenge. So the first one, you can see, we have a nice increase in cardiac output, and the second one also, we have a nice increase. So we optimize the macrocirculation of this patient. But when we look at the microcirculation, the sublingual microcirculation, you can see that after the first fluid challenge, we observe a nice improvement of the microcirculation. So it was good. But after the second fluid challenge, no change. So in terms of microcirculation, at the level of this tissue, the second fluid challenge was ineffective, was unuseful. And even worse, when you see the standard deviation, you can see that in some patients, we have a decrease in microcirculation. It is why the story is complicated. If, for example, you consider the kidney with the capsula, if you give too much fluid, initially it could be good because you improve the kidney blood flow. But you can increase the pressure, and this can be due to the capillary leak. And by increasing the pressure inside the kidney, you can compress the microcirculation. At the end, if you give too much fluid, you can be deleterious. So it's very important to know when it's good to give fluid, but also when we have to stop to give fluid. And a last example, it's concerning transfusion. So in this study, we give 1 unit of red blood cells. It's 250 milliliters of fluid and of blood. And in this patient, it's a hemorrhagic shock patient. And we observe that the effect at the level of microcirculation. And the physician do what he wants. It's an observational study. And you can see that despite the fact that we have apparently a good level of hemoglobin, it was 8.5 at the level of the macrocirculation, they give fluid, and what we observe at the level of microcirculation, we observe that in some patients, despite the fact that we have a systemic hemoglobin level, which was okay, at the microcirculation level, we have a deep alteration of microcirculation. And when we give only 250 milliliters of blood, we have a nice improvement of microcirculation. So it's, for me, it's clearly the fact that it's impossible to know, just at looking at your macrocirculatory parameters, how is your microcirculation, how is your tissue perfusion. And you know, we consider that in septic patient, in hemorrhagic shock patient, to have an hemoglobin level between 7 and 9 is okay. But maybe it's more complicated than this at the microcirculatory level. So how to assess perfusion at the bedside of our patient? Maybe by simple way, just at looking at patient, and it was the goal of this study, establishing a Mottling score. And you can see that it's when you have the highest score, the mortality was 92%, and when you have a score between 2 and 3, the mortality, you can see on the picture, your mortality was 70%. So very high. So when you have this kind of patient, the mortality is high. Just at looking at the patient, you know there is something wrong. So we have to do this, but I hope that after initial resuscitation, your patient are not in this shape. And I hope that it's my experience that we have plenty of patients who are very severe, and the Mottling score is 0. And especially in septic patients, where we have vasodilation. And we can have good macrocirculation, but it's not an impact on the peripheral circulation. So I think it's great, but it's not enough. So there is different approach. This I think it's interesting approach because it's a practical approach, looking at the forearm to fingertip skin temperature gradient. I think it's a very interesting concept to look at the temperature. the central to temperature difference, and looking at a peripheral flow index that you can have by pulse oximetry. And you can see that independently on the fact that the macrocirculation was okay in this study, you can see that there is clearly difference when you consider patients who increase their SOFA score versus patients who did not increase the SOFA score. There is a difference looking at these parameters, and clearly when you have an increase in SOFA score, you have clearly sign of peripheral hypoperfusion looking at these parameters. So I think that these parameters could be useful. There is an ongoing, I don't know if it starts or not, a multi-center study targeting specifically these parameters to see if by targeting tissue perfusion approach, you can do better than only targeting a macrovascular approach. So we will have the response, but I think that it's very interesting to work on this kind of indices, which are easy to have at the bedside, and especially the temperature. What about the CO2? The CO2 could be very useful because it's easy to use, and Massimo talked about this. And in this study, it's a prospective observational study in septic patients. And after goal-directed therapy, they look at arterial and mixed venous blood gases, and they look at the microcirculation, the sublingual microcirculation. And you can see that there is a nice correlation between the CO2 gap and the alteration of microcirculation. So for me, it's the indication that the CO2 is could be a good tool to assess microcirculation and tissue perfusion. So I think we need more study. And, but I think it's a very interesting tool. And you can see that, and it was an interesting point in this study, is that between T0 and T6, after 6 hours, they just look at the time course of the different parameters that they test, and after goal-directed therapy, and they observe that the evolution of the CO2 was parallel to the evolution of microcirculation. So it gives a strong correlation and the strong feeling that the CO2 is a good hypothesis, and we have to use it more in clinical practice. Because it's simple, and I think it clearly adds something to the lactate, because it's for me more peripheral index, more microcirculation index than the lactate. So is it possible to use a device like the sublingual microcirculation in our daily practice? Just this study from Daniel De Becker, it's in septic shock, and it looked at the microcirculation, sublingual microcirculation. It's just to show you that despite the fact they normalize the macrocirculation, the only parameters which were able to predict mortality in this study was a microcirculatory parameter. It was a percentage of perfused vessel. And you can see it's clearly very impressive compared to lactate, SVO2, or mean arterial pressure. So for me, it's the proof that looking at the sublingual microcirculation, it has clearly a significance considering outcome. So we try to see if nurses because this kind of device, we only use it in experimental setting. You can see if nurses are capable to use it, and just at looking as we do with echo, just at looking at picture and say, is it good, bad? Well, it's intermediate. So, you can see that by training nurses, establish a score, we get a good correlation and with what is capable to do a physician and with as a offline analysis. So it's the capability of nurses to do this at the bedside. And what is, for me, the most important is the sensitivity and the sensibility was very great to detect an alteration of microcirculation. And this point is very important because it's what we want. We want that nurses be able to say, there is something wrong. There is something wrong. The arterial pressure is okay, the cardiac index, but there is still something wrong. And it's, I want to use it as an alarm to say, oh, we have to do more. We have to do another thing. And it's clearly the idea of the other study where they establish a nice score. It's a visual score. And I think that we have to go to this direction and to try to use this technique at the bedside to evaluate our practice. So I take the kidney because we work a lot on this in my ICU. And I think that the echo is a promising tool to appreciate perfusion. And with echo, we can do the classical echo and look at the index of resistance at the level of the kidney. It's not very difficult to do after training, and it's easy to do at the bedside. And if you have this kind of profile with a very low diastolic velocity, it tells you there is something wrong. It could be hypovolemia. It could be that the pressure inside the kidney is too high. So it's, it gives you an indication. And if you, for example, you have to face to oliguria, it's easy to put the echo on the kidney. And if you have a resistive index greater than 0.7, so maybe I have to give more fluid. Maybe I have to increase the arterial pressure. And I can see by redoing echo if I improve the blood flow. Maybe the pressure inside the kidney is too high. I have to look at my CVP. And maybe my CVP is too high and it's a problem of congestion. Maybe I have an increase of the abdominal pressure and in compartmental syndrome. So it's useful, easy to do. And if it's okay, it's not a problem of flow. It's not a problem of pressure. I have not to give fluid to try to improve diuresis. It's another problem. It's a tubular injury. It's another problem. But I have not to give fluid. So, and there is several studies showing that it could predict acute kidney injury. It's a study that we perform in the unit, looking that it's better than biologic classical parameters to evaluate kidney function. And I think that we will have in the future improvement concerning echo technique, and I'm sure that it could be in the future very useful. I just want to share with you this result that we have with contrast-enhanced ultrasonography. We inject microbubble, and these microbubble are very, very echogenous. And we have very nice images. I just want to show you. It's in a pig where we perform experimental study, and you can see how you can have very nice visualization of microcirculation at the cortex, but also at the medulla. And so you can analyze the cortex, the medulla, so really you are inside the kidney. In a patient, it's a little bit more difficult, and you can have less nice image, but you can see that we have clearly a visualization of microcirculation, and we can assess this. We did this in septic patient, and it's 20 septic patient, and you can see that just look at first the resistive index, the classical one. You can see that clearly you have a difference between ICU patient, control patient without sepsis. Then it's the fact that the resistive index is a good tool for me to assess renal perfusion. And we observe, I just want to show you 3 pictures in this patient. We observe in some patient this, and it's comparison, when you compare to control, it's normal. So a normal perfusion. All the patients had similar macrocirculation and were optimized at this level. But in other patients, we had this kind of pictures. Nothing. Nothing. And this is the first day of admission. And in some patients, we have this, an hyperdynamic flow. So clearly, for me, it's the proof that in our patient, in septic patient, we are totally incapable to know what happened at the level of the different organ, even after optimization of macrocirculation. It's clearly for me that we have to work hard to find good tools to be able to monitor microcirculation, to be able to monitor oxygenation. And just to finish with this result, you can see that clearly there is a high heterogeneity between the patient. There is clearly a decrease of the perfusion index at the level of the kidney versus control group. And there is clearly a difference between patients with acute kidney injury and patients without acute kidney injury. So I think that this kind of technique, it's not easy to do at the bedside. We perform this only during this protocol. But for example, in my unit, because we have a lot of brain injury, we perform this kind of technique in subarachnoidal hemorrhage at the bedside. And so I think that contrast-enhanced echography could be in the future an interesting tool. I just want to show that it's in brain injury, it's in trauma brain injury, but the fact that we can monitor PO2 could be also very important. And this study of Pierre Bouza shows that if you consider intracranial pressure in this patient only or in addition to a PTO2, you can improve your RUG curve concerning the evolution of this patient. And it's only a retrospective study, but on this retrospective study, clearly, if you add the PTO2 to the monitoring of intracranial pressure, you clearly improve your outcome. So once again, it's the proof that we have to have more monitoring of tissue perfusion, and we have to apply this monitoring in our patient. So in conclusion, tissue perfusion and microcirculatory disturbance cannot be predicted by the assessment of global hemodynamics. Targeting therapy at the microcirculation may provide more individualized therapy and more complete resuscitation. We have to prove this, but there is, because most of the time right now it's indirect proof and retrospective proof. And so we need more real time technique at the bedside. And so there is a lot of work to do, but a so exciting story. Thanks a lot.